A disorder of any endocrine gland can profoundly affect the other endocrine glands as well as any major body system. In this chapter, we're going to discuss the care of clients with various endocrine disorders and consider the way in which these disorders affect systemic physiology. This chapter focuses on disorders affecting the pituitary, thyroid, parathyroid, and adrenal glands. We are going to describe the physiological effects of hyposecretion and hypersecretion of the pituitary, thyroid, parathyroid, and adrenal glands. We're going to describe the nursing management of clients with pituitary gland disorders, describe thyroid disorders and nursing management of clients with these disorders, compare the differences in physiologic effects, assessment findings, and management of disorders affecting the parathyroid glands, identify disorders of the adrenal glands, and describe nursing management of clients with these disorders. And finally, we'll identify symptoms of emergency conditions resulting from endocrine disorders. So before we go into acromegaly, we need to talk about disorders of the pituitary gland. Now, pituitary gland disorders usually result from excessive or deficient production and secretion of specific hormones. When there is an oversecretion of the growth hormone that occurs before puberty, the long bones are not yet fully united. What'll happen is gigantism results. When secretion of growth hormone during childhood is insufficient, then we get dwarfism. So let's talk about acromegaly. So oversecretion of growth hormone during adulthood results in acromegaly. So basically what happens is the growth hormone is oversecreted after the epiphyses of the long bones have sealed. Growth hormone is overproduced when the pituitary gland is insensitive to feedback inhibiting hormones such as somatostatin, a hypothalamic hormone, and insulin-like growth factor 1, which is IGF-1. This is a hormone that's released by the liver and stimulates the growth of bones and tissue. And unchecked growth hormone allows sustained production of the IGF-1, a hormone synthesized and secreted by the liver, which supports cellular division and growth, but is less potent than insulin. So the sustained production of the IGF-1 will lead to lengthening and widening of your bones, organ enlargement, and hyperlipidemia. The hypersecretion causes hypertrophy, which means your cell size increases. So hypersecretion causes hypertrophy and hyperplasia, which means an increased number of cells. So basically, the size of the cell is getting bigger as well as the number of cells that are increasing. And this results in adenoma, which is a benign tumor. As with other cranial tumors, a benign pituitary tumor becomes a space-occupying lesion and can affect other cerebral structures. So when we're assessing somebody that may or may not have acromegaly, we are going to find that somebody with acromegaly has very coarse features, like a huge lower jaw, thick lips, a thickened tongue, a bulging forehead, a very bulbous nose, and large hands and feet. When the overgrowth is from a tumor, headaches caused by the pressure on the sella turcica, a bony depression where the pituitary gland lies, is common. Partial blindness can also result from pressure on the optic nerve. The heart, liver, and spleen might be enlarged, and despite the enlarged tissues, we find that muscle weakness is pretty common, and they also have hypertrophied joints, which become painful and stiff. They also might get osteoporosis of the spine and joint pain. Many men experience erectile dysfunction, and women may have an absence of menstruation, increased facial hair, deepened voices that result from compression of areas of the pituitary gland responsible for producing gender-related hormones. Some people also might develop diabetes mellitus. So, in order to diagnose acromegaly, we can do things like skull radiography, MRI, CT scans, and what this will do is it will reveal pituitary gland enlargement. But we can do bone radiographs, and this will show thickened long bones and skull bones. A glucose tolerance test in combination with a growth hormone measurement is the most reliable method of confirming acromegaly. We can do ingestion of a bolus of glucose, and this should lower growth hormone levels, but hormone levels will remain elevated in persons with acromegaly. Increased blood levels of the IGF-1 can also indicate acromegaly in non-pregnant women who typically have IGF-1 levels 2 to 3 times higher than normal in pregnant women. So to treat this, the treatment choice is going to be a hypophysectomy, which is the surgical removal of the pituitary gland, and this lies within the sella turcica, a saddle-shaped depression in the sphenoid bone. The gland is removed by piercing the sphenoid with either a sublabial approach or with a minimally invasive endoscopic endonasal method. So sublabial is under the lip, under the upper lip, and the endonasal is through the nose. The endonasal does reduce surgical trauma and leaves no residual scar and results in a recovery time of 2 days. However, because the pituitary gland is surrounded by the optic nerves and carotid arteries, many physicians who use the endoscopic technique request assistance from a neurosurgeon, an otolaryngologist, a neuro-ophthalmologist, or interventional radiologist. We also have to remember that the client who is at surgical risk may undergo a primary method of treatment that includes a series of radiation over 4 to 6 weeks. These patients require frequent monitoring for evidence of tumor recurrence, and even if the disease is arrested successfully, physical changes are irreversible. If the surgery or radiation removes or destroys normal pituitary tissue, replacement therapy with thyroid hormone, corticosteroids, antidiuretic hormone, and sex hormones is necessary. So some medical treatment will include oral administrations of bromocriptine mesylate, which is Parladel, an oral anti-Parkinson drug that inhibits release of growth hormone in clients with acromegaly. Or we can also give cabergoline, which is Dostinex, and this is we can also give parenteral injections of sandostatin and somatoline and Somavert. So bromocriptine and cabergoline are used alone or in conjunction with pituitary gland irradiation or surgery to reduce the serum growth hormone level. Octreotide, a synthetic form of somatostatin, stops the production of growth hormone and IGF-1 and effectively will relieve the symptom for a short time. One form of octreotide is injected subcutaneously every 8 hours, but there's a longer acting form, which is sandostatin LAR depot, which is injected intramuscularly every month. Both forms may cause GI side effects, gallstone, and diabetes. Pegvisomant, a growth hormone receptor antagonist, is the newest and most effective drug for treating acromegaly. Injected subcutaneously once a day, it normalizes the IGF-1 level by blocking the growth hormone stimulation of IGF-1 produced by the liver. So until the patient has surgery or receives radiation treatment, our responsibility is to help the patient cope with changes in their physical appearance and pace the activities to accommodate their fatigue and relieve any discomfort from headaches, abdominal distension resulting from an organ enlargement, and any kind of skeletal pain. We want to evaluate their pain, figure out what kind of pain it is, the location, and give any analgesics as prescribed. We also want to make sure that we are encouraging self-care and activities as long as their strength and endurance permit. So, patients may experience severe psychological stress, mainly because of the prominent physical changes that happen, as well as sexual dysfunction and decreased libido. We are here to help the client cope with these kind of changes. So if they do express concern over sexual dysfunction, we do want to bring it to the doctor's attention so that maybe a sex therapist might be indicated. Post-operatively, the patient might go under frequent neurologic assessments, and we do this to detect signs of increased intracranial pressure and meningitis. If they do have nasal packing post-operatively, we want to monitor drainage from the nose and postnasal drainage for the presence of cerebrospinal fluid. We also want to modify oral and facial hygiene to promote cleanliness without contributing to trauma near the operative site. We want to remind them to avoid drinking from a straw, sneezing, coughing, and bending over to prevent dislodging the graft that seals the operative area between the cranium and the nose. Question number 1. Is the following statement true or false? Acromegaly is caused by oversecretion of growth hormone before puberty. False. Acromegaly is caused by oversecretion of growth hormone during adulthood. Gigantism is caused by oversecretion of growth hormone before puberty. Simmons disease is a rare disorder caused by destruction of the pituitary gland followed by cessation of pituitary hormonal activity. So, events such as postpartum emboli or hemorrhage, surgery, tumor, or tuberculosis can destroy pituitary function. This disease affects all hormones of the anterior pituitary gland. So, in assessing, the gonads and genitalia will atrophy. Because of the impaired pituitary stimulus, the thyroid and the adrenals fail to secrete adequate hormones. And some signs and symptoms are hypothyroidism, hypoglycemia, and adrenal insufficiency, which is also called Addison's disease. The patient will prematurely age as well as become extremely cachetic, which is physical wasting. The skin will then become pale because of a decrease in melanocyte stimulating hormone, and this is under the control of the adrenocorticotropic hormone, ACTH. And results of their lab tests will actually show decreased hormone levels in, for example, thyroid, corticosteroid, and reproductive hormones. So, treatment will include administration of replacement hormones for the glands that depend on the pituitary gland for stimulation. If it's untreated, the disease is fatal. Growth hormone replacement is necessary only for children, and deficiency of the thyroid stimulating hormone, TSH, will require replacement with levothyroxine or liothyronine for the client's lifetime. So that means that they can never not take it. It's not a temporary fix. This is something that they will always have to take. Male clients will receive testosterone, and while female clients will receive estrogen, and both sexes receive follicle stimulating hormone and luteinizing hormone. So our responsibility as nurses is that we're going to administer all hormone replacements as prescribed. We're going to give education to the client to adhere to the medication schedule and never miss a dose. We're going to monitor their blood hormone levels, assess their mental status, emotional state, energy level, and appetite. We want to make sure we're paying attention to any alterations in nutrition. We found that most people with Simmons disease tolerate 4 to 6 small meals per day rather than 3 regular to large meals. Question number 2. Is the following statement true or false? A sign of panhypopituitarism is premature aging. True. A sign of panhypopituitarism is premature aging. Also included in the signs and symptoms are hypothyroidism, hypoglycemia, adrenal insufficiency, gonads and genitalia atrophy, and cachexia. Diabetes insipidus is a disorder characterized by the excretion of extremely large volumes of urine. So there are two. Neurogenic or central diabetes insipidus develops when there is insufficient antidiuretic hormone, which is also known as vasopressin. A second type is called nephrogenic diabetes insipidus, and both have identical symptoms, but the difference with nephrogenic diabetes insipidus is that the secretion of antidiuretic hormone is normal, but the receptors in the renal tubules will either partially or completely fail to respond to the hormone. So, antidiuretic hormone is secreted by the posterior pituitary gland, and this regulates the reabsorption of water in the kidney tubules. Its function is to increase circulating fluid volume. Antidiuretic hormone is released in response to thirst and fluid losses such as hemorrhage, which will lower blood pressure. Antidiuretic hormone can also raise blood pressure by signaling the peripheral arterioles to constrict, and that's how it gets its name, vasopressin. So, in knowing all that information, a lack of antidiuretic hormone secretion or an ineffective response to it will cause the client to produce large volumes of dilute urine. If the patient fails to drink a compensatory volume of fluid, dehydration with concentrated levels of electrolytes will occur. So, neurogenic diabetes insipidus can result from head trauma that damages the pituitary gland or from primary or metastatic brain tumors. In some congenital instances, the symptoms can occur shortly after birth. It can also occur in a hypophysectomy, which is the surgical removal of the pituitary gland. On the other hand, nephrogenic diabetes insipidus is actually less common than neurogenic diabetes insipidus. The person that usually gets nephrogenic diabetes insipidus is usually from side effects of drugs such as lithium, declomycin, and amphotericin B. And most of the time, as long as we reverse these drugs, the symptoms will also reverse as well. In assessing somebody with diabetes insipidus, you'll find that urine output can be as high as 20 liters for 24 hours. The urine will be dilute with a specific gravity of 1.002 or less, and limiting fluid intake won't actually control the urine excretion. The thirst is always going to be excessive and constant, so we have to make sure that activities are limited because of the frequent need to drink and void. You'll find that when you're assessing them, the symptoms they generally complain of are weakness, dehydration, and weight loss. Before we medically manage diabetes insipidus, we need to make sure we know how to diagnose. So, usually a fluid deprivation test can diagnose diabetes insipidus and differentiate neurogenic diabetes insipidus from nephrogenic diabetes insipidus. And once we do that and we can find the difference between the two, then we can manage. So, the DD-AVP, which stands for desmopressin acetate, and lipressin, which is diapid. So desmopressin acetate and lipressin nasal spray are synthetic drugs with antidiuretic activity that reduces urine output from 2 to 3 liters every 24 hours. So this is quite different, right? Because in the previous slide, we talked about saying that urine output could be anywhere from 20 liters every 24 hours. So we'd be bringing it down to 2. So we are literally getting rid of 18 liters of urine. If the client can't take oral fluids to meet the excessive fluid volume loss, we might have to give IV fluids as necessary. So, the management of nephrogenic diabetes insipidus is different. Besides ensuring that the patient has had a sufficient intake of fluid, the doctor also needs to reduce the client's urine output by reducing the amount of sodium excreted by the renal tubules. So, therefore, the doctor is going to restrict the patient's use of dietary sodium. They might prescribe a thiazide diuretic, such as hydrochlorothiazide. And this thiazide will act as the proximal convoluted tubule, which leaves less fluid for excretion in the distal convoluted tubules, which is the portion that's affected by nephrogenic diabetes insipidus. Consequently, the patient will excrete water, but the total volume is less than in an untreated state. So sometimes the doctor will prescribe the thiazide diuretic combined with spironolactone or amiloride, which are potassium-sparing diuretics, to help prevent hypokalemia. In addition, the doctor will prescribe indomethacin, which is an anti-inflammatory drug that will act as a prostaglandin inhibitor to reduce the level of prostaglandin E2. And lastly, the doctor will restrict the client's intake of dietary protein to reduce the work of the kidney to excrete protein nitrogenous waste. So our responsibility as nurses, we want to make sure we are correcting fluid volume deficit. We want to make sure we are closely monitoring the rate of IV infusions to ensure that the prescribed amount is given or over the required period, and measure their fluid intake and output. So if the patient is acutely ill or extremely dehydrated and fails to take oral fluids, or even at the beginning of medical treatment, we want to make sure we are measuring their urine output every 30 minutes while administering prescribed fluid and drug therapy. We want to weigh the client daily to identify any weight gain or weight loss and observe for signs of fluid excess or deficit. We want to teach the patient to consume sufficient fluid to control thirst and to compensate for urine loss. In addition, we want to explain other methods for reducing fluid loss, such as remaining in air-conditioned areas during hot and humid weather and avoiding strenuous activity. It is really important that we stress their adherence to drug and diet therapy to make sure that the client has treatment that can control their symptoms. The syndrome of inappropriate antidiuretic hormone secretion is characterized by renal absorption of water rather than its normal secretion. So in the next minute or so, I'm going to be using SIADH in order to identify syndrome of inappropriate ADH secretion. It's a little bit easier to say. So causes of SIADH include lung tumors, central nervous system disorders, brain tumors, a cerebrovascular accident, head trauma, and drugs such as vasopressin, general anesthetic agents, oral hypoglycemics, and tricyclic antidepressants. The continued release of antidiuretic hormone increases fluid volume and causes hyponatremia. In assessing this, water retention, headache, muscle cramps, and anorexia develop. And so as it worsens, the patient will experience nausea, vomiting, muscle twitching, and changes in their level of consciousness. So in order to diagnose this, we base it on the symptoms and a history of a disorder associated with SIADH. We find that serum sodium levels and serum osmolarity are decreased, and urine sodium levels and osmolarity are high. So, when it is possible, the treatment will aim at eliminating the underlying cause. So, osmotic diuretics such as mannitol and loop diuretics like Lasix will help correct water retention. Severe hyponatremia, though, is treated with IV administration of a 3% hypertonic sodium chloride solution. So, our responsibility as a nurse is to monitor their fluid intake and output and their vital signs. We're going to want to carefully assess the their level of consciousness, and immediately report any changes to the physician. We want to check closely for signs of fluid overload, such as confusion, dyspnea, pulmonary congestion, and hypertension. And also watch out for hyponatremia, which are signs of weakness, muscle cramps, anorexia, nausea, diarrhea, irritability, headache, weight gain without edema. We want to give the patient and their family extensive information about the medication schedule and adverse effects of drug therapy, especially if several medications are prescribed. We want to make sure we really stress the importance of adhering to this medication schedule and never missing a dose. Hyperthyroidism is also called Graves' disease or Bastard's disease, thyrotoxicosis, or exophthalmic goiter. So there's no single etiology for hyperthyroidism. Researchers have suggested that it may be autoimmune or inherited. Hypersecretion of thyroid hormones accompanies thyroid tumors, pituitary tumors, and hypothalamic malignancies. It can also result from stress or infection, and the metabolic rate increases because of the oversecretion of the thyroid hormones thyroxine and triiodothyronine. So thyroxine is known as T4 and triiodothyronine is T3. So both T4 and T3 increase the metabolic rate, and hyperthyroidism is actually more common in women than it is in men. And so in knowing all this information, when we assess, symptoms can kind of vary from mild to severe. So patients with hyperthyroidism characteristically are restless despite feeling very tired and weak. They're usually highly excitable and constantly agitated. You'll find that there are fine tremors of their hand that will occur, causing unusual clumsiness. Patients usually cannot tolerate and have an increased appetite, but they still tend to lose weight, and they also have diarrhea. Visual changes such as blurred or double vision can develop, and exophthalmos, which is seen in clients with severe hyperthyroidism, will result from enlarged muscle and fatty tissue surrounding the rear and sides of the eyeball. So as you can see in this picture on the left, her eyes jut out a little bit. So that what is called exophthalmos. So neck swelling caused by the enlarged thyroid gland is often visible. And if you look on page 896 on table 50-1, it compares the signs and symptoms of hyperthyroidism and hypothyroidism. So to diagnose hyperthyroidism, we are looking for the protein-bound iodine, free thyroxine FT4 that is not bound to protein, thyroglobulin, and serum T3 and T4, because when we look at those lab levels, they are elevated. The TSH level will be decreased, and if we do a thyroid ultrasonography, it'll show an enlarged thyroid gland. A thyroid scan indicates an increased uptake of radioactive iodine throughout the gland or confined to a single nodule. So, in medically and surgically managing Graves' disease, antithyroid drugs such as propylthiouracil and methimazole, these are given to block the production of thyroid hormone preoperatively or for long-term treatment for clients who are not candidates for surgery or radiation treatment. If the patients receive antithyroid drugs as the only treatment and do not comply with prescription therapy early in its management, this disorder will or may reactivate. About 40% to 70% of those who comply with antithyroid drug therapy for 1 to 2 years will experience remission, but they need to continue with follow-up care to detect any signs of reoccurrence. Antithyroid drugs can curb thyroid activity before surgery to reduce the post-operative potential for bleeding and thyrotoxicosis. Antithyroid medications, however, are avoided during pregnancy because they can include hypothyroidism or cretinism in the fetus. So there is something called 131I, and this is used to destroy hyperplastic thyroid tissue by radiation. Now, the thyroid is quick to remove iodine, including RAI, from the bloodstream, and antithyroid drugs are given for 6 months or more before administration of 131I. Now, if the symptoms do not improve, a second and perhaps a third dose of 131I is given, and about 6 to 8 weeks after the first dose of 131I, most patients will notice some remission of symptoms. This extended time lag before relief of symptoms is a disadvantage of this treatment method, though. A more common and unfortunate result of treatment is hypothyroidism, because accurately determining the precise amount of thyroid tissue that radiation will destroy is very difficult. Now, this complication may not develop until long after the administration of 131I, so patients have to remain under medical supervision for many years. We can also do a thyroidectomy, which is a removal of part or all of the thyroid gland. A subtotal thyroidectomy is a partial removal of the thyroid gland, or a partial thyroid lobectomy is a removal of the upper or lower portion of one lobe, and these are an effective treatment for a confined area or nodule within the thyroid that is increasing production of thyroid hormones. Occasionally, an entire lobe with or without the isthmus is removed, and a total thyroidectomy, which is removal of the entire thyroid gland, is performed if a cancerous tumor is present or if the hyperthyroidism is in an advanced stage and involves all of the glandular tissue. Those who have a small thyroid nodule or a thyroid volume less than 30 milliliters may be candidates for minimally invasive surgery with an incision that measures about 1/2 inch to 1 inch as compared to a traditional thyroidectomy incision of 2 to 4 inches. Now, with most minimally invasive techniques, the advantages are less blood loss, less pain, shorter recovery time, and an almost imperceptible scar. Those that commonly receive antithyroid drug therapy for several weeks before surgery to prevent a dramatic release of thyroid hormones into the bloodstream during surgery. Some complications, though, of thyroidectomy include the following: accidental removal of or alteration in the blood supply to the parathyroid glands, which are embedded in thyroid tissue, resulting in hypocalcemia. One or more parathyroid glands may be reimplanted into nearby muscular tissue where they will eventually attach, grow, and function normally. You can also get hemorrhage caused by the vascularity of the thyroid and surrounding tissue. You can go through thyrotoxicosis or a thyroid storm as a result of excessive secretion of thyroid hormones during surgical excision. And last but not least, you can damage the recurrent laryngeal nerve, which affects the function of the vocal cords. If the recurrent laryngeal nerve is damaged either temporarily or partially, breathing can be impaired because the vocal cords cannot open properly during inspiration. The voice will sound weak, hoarse, or breathy, and aspiration and pneumonia may occur if the vocal cords don't close completely during swallowing. So our responsibility as a nurse is to monitor the respiration, heart rate, and blood pressure regularly. The evidence of bleeding may be present on the anterior dressing or that which may drain behind the neck, and we have to make sure that we are assessing these frequently. We want to see if there's any manifestation of hypocalcemia, and we use the way we assess this is the Chopstek's and Trousseau's sign, and also involuntary muscle spasms in the event the parathyroid glands have been accidentally removed. He or she will record the patient's sleep pattern and daily weight, and the nurse will promote rest and help the client avoid excess physical stimulation. We might want to increase their caloric intake because it can compensate for their increased metabolism. We also want to inform the patient that effects of antithyroid therapy usually are not apparent until the thyroid gland ceases to secrete the excess thyroid hormone into the bloodstream, but this may take several weeks or more. So, if RAI is used to destroy thyroid tissue, we have to make sure we tell the patient that it does not seriously affect other tissues, but possible transient effects after the use of 131I are nausea, vomiting, malaise, fever, and gland tenderness. Thyrotoxic crisis is also known as a thyroid storm or thyrotoxicosis, and which is an abrupt and life-threatening form of hyperthyroidism, and it's thought to be triggered by extreme stress, infection, diabetic ketoacidosis, trauma, toxemia of pregnancy, or manipulation of a hyperactive thyroid gland during surgery or physical examination. Now, although it's rare, this condition can occur in patients with undiagnosed or inadequately treated hyperthyroidism. The oversecretion of T3 and T4 is followed by a release of epinephrine. So metabolism is markedly increased. The adrenal glands will produce excess corticosteroids in response to the stress, which is created by their hypermetabolic state. So when we assess somebody that might be going through a thyrotoxic crisis, we can find that the temperature may be as high as 106 Fahrenheit or 41 degrees Celsius. We'll find that their pulse rate is rapid and cardiac arrhythmias are common. The patient may experience persistent vomiting, extreme restlessness with delirium, chest pain, and dyspnea. When we diagnose them, it's based on the symptoms in a recent medical history that will indicate the symptoms of severe hyperthyroidism. Lab tests such as a thyroid panel with measurements of TSH, serum T3, and T4 will be used to confirm the diagnosis. In a thyrotoxic crisis, serum T3 and T4 lab values are markedly elevated. So, in treating, immediate treatment is absolutely necessary for a thyroid storm. Antithyroid drugs such as PTU or methimazole are used to block the synthesis of thyroid hormones. An IV corticosteroid may be given to replace depletion that results from overstimulation of the adrenals during the hypermetabolic state. IV sodium iodide will prevent the thyroid gland from releasing additional thyroid hormones. Propranolol, a beta blocker, will reduce the effect of thyroid hormones on the cardiovascular system, and supportive therapies include IV fluids, antipyretic measures, and oxygen therapy. Our responsibility as a nurse with somebody who is in a thyrotoxic crisis is to monitor their vital signs, especially their temperature, pretty frequently. When we fail to respond to an antipyretic drug, when the patient fails to respond to an antipyretic drug, some other measures are taken, such as a cooling blanket or an ice application, or we can even put them in a cool room, and this can help reduce their body temperature. Hypothyroidism occurs when the thyroid gland fails to secrete adequate thyroid hormones. So this condition can originate in the thyroid or in the pituitary gland, in which case insufficient TSH is secreted. Now, regardless of the cause, inadequate thyroid hormone secretion results in a slowing of all metabolic processes. So severe hypothyroidism is actually called myxedema. Advanced untreated myxedema can progress to myxedemic crisis, or what some call a myxedemic coma. Now, signs of this life-threatening event are hypothermia, hypotension, and hypoventilation. A patient with hypothyroidism experiencing an infection, trauma, excessive chills, taking narcotics, sedatives, or tranquilizers may develop myxedemic crisis. When we assess, the signs and symptoms are opposite of those of hyperthyroidism in many respects. Metabolic rate and physical and mental activity slow down. The patient will be lethargic, lack energy, they'll doze frequently throughout the day, they'll be forgetful, and have chronic headaches. The patient will take on a mask-like unemotional expression, yet the patient will often be irritable. The tongue may be enlarged and the lips swollen, and there may be edema of the eyelids. Their temperature and pulse rate will be decreased, and the patient will be intolerant to cold, so they won't like the cold. Their weight will increase despite a low caloric intake. Their skin will be dry, and hair characteristically is coarse and sparse and tends to fall out. Menstrual disorders are usually pretty common, and constipation can be severe, and the voice is low-pitched and hoarse, and the speech is low. Hearing may also be impaired, as well as the patient may experience numbness or tingling in the arms or legs that is unrelieved by position change. So, hypothyroidism can lead to an enlarged heart caused by a pericardial effusion and an increased tendency towards atherosclerosis and excessive effort by the heart to pump blood. We can find that anemia might also be present, and early recognition of hypothyroidism is difficult because many of the symptoms are very nonspecific and may not be sufficiently dramatic enough to bring the patient to the physician. So hypothyroidism can actually go untreated for many years. So the way we would diagnose this, in primary hypothyroidism, levels of TSH are increased because of the negative feedback to the pituitary gland. And so that is the low levels of thyroid hormones that cause the pituitary gland to increase secretion of TSH. The level of FT4 will be decreased, and the RAI uptake may be decreased. The T3 and T4 levels will show no response in primary untreated hypothyroidism, but may show a response if hypothyroidism results from failure of the pituitary gland to secrete TSH. So, hypothyroidism is treated with thyroid replacement therapy. The thyroid hormone in the form of desiccated thyroid extract or with one of the synthetic products such as levothyroxine or liothyronine sodium are oral thyroid preparations. A low dose of thyroid hormone is given initially and then increased or decreased until the optimal dose is achieved. Some symptoms associated with hyperthyroidism and hypothyroidism will often affect learning and retention ability, and so the nurse carefully explains the treatment regimen, including the dose of the medications and possible adverse effects. If a special diet has been recommended, the nurse will then obtain a dietary consultation and review sample diets with the patient. A teaching plan will include weighing themselves weekly, avoiding stressful situations, maintaining good nutrition, and notifying the physician if the symptoms or adverse effects occur. So tumors of the thyroid can cause hyperthyroidism, and they're more commonly known as being benign, but all nodules still have to be evaluated. A follicular adenoma is the most common benign thyroid lesion. A thyroid nodule is most likely this type in adult women, but as it gets bigger, surgical excision and pathological examination are necessary to be absolutely sure. Papillary carcinoma is the most common malignant lesion and usually occurs in patients who have received radiation treatments to the head or neck region in the past. It tends to spread only to nearby lymph nodes and will rarely spread to other parts of the body. But the cure rate of thyroid cancer depends on the type of tumor. In assessing somebody with a thyroid tumor, symptoms tend to be kind of vague, and the patient may be unaware of the lesion. Usually with a routine physical examination, this will reveal a nodular thyroid. As the tumor gets bigger, the patient will often notice a swelling in their neck. Benign tumors will cause symptoms of hyperthyroidism in some clients, and malignant tumors can cause voice changes, hoarseness, difficulty swallowing. Biopsy of the lesion will confirm the diagnosis, and thyroid cancer is suspected when the gland is firm and palpable, and results of the RAI studies show poor concentrations in the suspect area. In treating this, if there are no symptoms of hyperthyroidism with a benign nodule, treatment is usually not needed. Now, this nodule will be examined yearly, and if the enlargement causes symptoms such as difficulty swallowing and noticeable neck swelling, then we would look into surgical removal of the lesion. So, although treatment of malignant lesions vary, a thyroidectomy, which is a total or subtotal removal of that tumor, is typically performed. A modified radical neck dissection is indicated if there is metastasis, which means it has spread. And after a thyroidectomy, thyroid hormone replacement is given to restore thyroid function and to suppress pituitary TSH so that it no longer stimulates growth of residual thyroid tissue. 131I is administered to destroy remaining thyroid tissue as well as to treat lymph node metastasis if present. Now, if the thyroid tumor is malignant, the doctor is going to explain the planned treatment and expected outcome, and we are here to provide emotional support, especially if the tumor has metastasized and radical surgery is necessary. When RAI is used after surgery, the patient will be isolated and placed on radiation precautions, and we're going to be very careful in handling their body fluids to prevent radioactive contamination. When we talk about the word goiter, goiter refers to an enlarged thyroid gland. So, an endemic goiter is caused by a deficiency of iodine in the diet, by the inability of the thyroid to use iodine, or by relative iodine deficiency caused by increasing body demands for thyroid hormones. A non-toxic goiter, also called simple or colloid goiter, is an enlarged thyroid, usually with no symptoms of thyroid dysfunction. This gland may enlarge as a result of consuming excessive goitrogenic foods such as gluten, soy products, and cruciferous vegetables such as broccoli and Brussels sprouts, peanuts, pine nuts, and flaxseed, or even taking certain drugs such as lithium that may cause hyperplasia of the gland. Nodular goiters contain one or more areas of hyperplasia, and this type of goiter appears to develop for essentially the same reasons as an endemic goiter. So when we assess, we find that the thyroid gland will enlarge, and the patient has a sense of fullness in the neck area. When the gland continues to enlarge, eventually it will result in difficulty swallowing and breathing as the thyroid presses on the trachea and esophagus. When the gland has enlarged, it's visible as a swelling in the neck. Nodular goiters also produce enlargement, but the gland has an irregular surface on palpation. We can find this by a thyroid scan, which will show an enlarged gland and a decreased uptake of 131I. Sometimes we do tests of thyroid function that are performed, but the results may or may not be abnormal, and thus they might be inconclusive. In managing this, treatment depends on the cause. So if the diet is deficient in iodine, foods high in iodine such as seafood or iodized salt are recommended. Potassium iodide to supplement iodine intake may also be given. But in some instances, a thyroidectomy is recommended, especially when the gland is grossly enlarged. Our responsibility as a nurse, if the patient has respiratory distress because of the enlarged thyroid, we want to make sure we are observing respiratory status as well as elevating the head of their bed to relieve any respiratory symptoms. We might have to provide them a diet high in iodine and iodized salt. Natural iodine content is highest in seafood and shellfish, and is found in varying amounts of bread, milk, eggs, meat, and spinach. Fish, lentils, and yogurt are also non-goitrogenic alternatives to soy protein, and a soft diet might be necessary if the patient has difficulty swallowing. Thyroiditis is an inflammation of the thyroid gland, which can be acute, subacute, or chronic. So there are multiple etiologies, and consequently, the subtypes of thyroiditis that involve inflammation of the gland release higher than normal levels of hormones and changes in thyroid function from hyperactivity to hypoactivity. So inflammation will cause the gland to enlarge and become tender in some cases. Excess thyroid hormone will release from stores within the thyroid gland rather than from stimulation from the pituitary gland, which will produce a hypermetabolic state. As the stores of the thyroid hormone deplete, a hypometabolic state will ensue. And in some cases, the thyroid gland recovers, but in other cases, hypothyroidism will become permanent. So, acute thyroiditis is the most common in children and will appear to result from a bacterial infection of the gland. Acute thyroiditis is fairly rare to the efficacy of antibiotic therapy. So, one type of subacute thyroiditis can follow an upper respiratory viral infection, and the most common type is Hashimoto's thyroiditis, which is a chronic form of thyroiditis believed to be an autoimmune disorder that develops in the postpartum period. In assessing, the signs and symptoms of acute thyroiditis include high fever, malaise, and tenderness and swelling of the thyroid gland. Subacute thyroiditis produces symptoms of a swollen and painful or painless gland. Chills, fever, and malaise approximately 2 weeks after infection accompany thyroiditis of a viral etiology. When signs of hyperthyroidism develop, the patient will experience tachycardia, tremors, intolerance of heat, weight loss, and emotional irritability. Now, once the gland is destroyed, symptoms of hypothyroidism such as lethargy, weight gain, weakness, constipation, and dry hair will develop. To diagnosis, in acute thyroiditis, lab results will show an elevated white blood cell count. During a thyroid scan, inflamed and damaged thyroid cells will fail to concentrate RAI. And during the hypermetabolic phase of the disease, thyroid function tests will elevate. In the situation of Hashimoto's thyroiditis, high titers of antimicrosomal and antithyroglobulin antibodies are evident, reflecting the autoimmune nature of this disease. So, in medically managing thyroiditis, acute thyroiditis will require administration of appropriate antibiotics. The treatment of subacute thyroiditis is symptomatic and will include analgesics for pain and discomfort. Corticosteroids will also be prescribed to reduce inflammation, and the treatment of Hashimoto's thyroiditis will include thyroid hormone replacement therapy. Surgery might be required if the gland becomes excessively large. In taking care of this, nursing management depends on the type of thyroiditis and severity of symptoms. So we want to give antipyretics for fever, elevate the head of their bed if they have difficulty breathing, and maybe offer a soft diet if the gland is markedly enlarged and the patient has difficulty swallowing. If the patient has undergone surgery, we want to instruct the patient before discharge about the care of the surgical wound and to avoid excessive strain on the wound until it's healed. Because the incision is made in a neck crease, the healed scar is going to be barely visible. And so if the patient appears concerned about scarring, we might suggest that they can wear clothing that covers the neck until the scar is almost invisible. We also would like to discuss the symptoms of hypothyroidism, hyperthyroidism, and hypoparathyroidism with instructions to notify the doctor if any of these occur. If the medication is prescribed, the nurse is going to review the dosage, schedule for self-administration and adverse effects of each drugs, and offer a teaching plan which includes techniques for wound care and the need to take thyroid replacement medication in the morning at the same time each day to avoid insomnia and CNS stimulation and side effects that require notification of the physician. Is the following statement true or false? The etiology of Graves' disease is the hyposecretion of thyroid hormones. False. The etiology of Graves' disease is the hypersecretion of thyroid hormones. Hyperparathyroidism is an excess of parathormone, which can be primary or secondary condition. So the most common cause of primary hyperparathyroidism is an adenoma, which is a benign tumor of one of the parathyroid glands. In primary hyperparathyroidism, excessive secretion of parathyroid hormone will remove the calcium from the bones. The bones then become demineralized as the calcium leaves and enters the bloodstream, and renal stones can develop when calcium becomes concentrated in the urine. In secondary hyperparathyroidism, the parathyroid glands secrete excessive parathormone in response to hypocalcemia, which may result from vitamin D deficiency, chronic renal failure, large doses of thiazide diuretics, and excessive use of laxatives and calcium supplements. In assessing this, excessive calcium in the blood depresses the responsiveness of the peripheral nerves, which account for fatigue and muscle weakness. The muscles will then become hypotonic and cardiac arrhythmias may develop. Now, because the bones have lost their calcium, there is skeletal tenderness and pain on bearing weight. And the bones may become so demineralized that they break with little or no trauma. Other possible side effects will include nausea, vomiting, and constipation, large amounts of calcium and phosphorus passing through the kidneys, which predispose the client to formation of stones in the urinary tract, pyelonephritis, and uremia. So the diagnosis is based on elevated serum calcium and decreased serum phosphorus levels, when other causes of hypercalcemia are excluded. The results of a 24-hour urine test will show that increased urine calcium levels. Skeletal radiographs can also show calcium loss from the bones, and an MRI or CT scan can identify a parathyroid adenoma if it is present. As noted earlier, parathormone levels are elevated in hyperparathyroidism. So secondary hyperparathyroidism is managed by correcting the cause. So for example, vitamin D therapy for a vitamin D deficiency, correcting the renal failure, or a calcium-restricted diet. Sodium and phosphorus replacements can often be ordered, and hormone replacement with synthetic calcitonin is avoided because it's associated with allergic reactions and drug resistance. It's usually caused by antibodies that neutralize the hormone. So the only treatment for primary hyperparathyroidism is the surgical removal of hypertrophied glandular tissue or of an individual tumor of one of the parathyroid glands. But before surgery, the doctor has to determine the number of the 4 glands to be removed based on the cause of hyperparathyroidism and the laboratory and diagnostic test results. One or more of the parathyroids is left in place to maintain the calcium and phosphorus metabolism. We want to make sure we closely monitor their intake and output, observe for signs of urinary calculi from hypercalcemia, flank pain, and decreasing urine output. We want to also encourage a large volume of fluid to keep the urine dilute, and assess the patient's ability to perform self-care, provide a safe environment to prevent falls, make sure we encourage frequent rest periods, and monitor the fatigue level. Our main responsibility is to teach the patient about the effects of this disease, the planned medical management, and the importance of following the prescribed treatment. If the patient does undergo surgery, the management is similar to that for thyroid surgery, and in addition, the nurse must observe the client for symptoms of hypoparathyroidism. Hypoparathyroidism is a deficiency of parathormone that will result in hypocalcemia. Hypocalcemia affects neuromuscular functions, and it causes hyperexcitability, resulting in spastic muscle contractions and paresthesis. Paresthesis is abnormal sensations. Now, the most common causes of hypoparathyroidism are trauma to the glands and inadvertent removal of all or nearly all these structures during a thyroidectomy or parathyroidectomy. The idiopathic form of this disorder is rare, but may be autoimmune in origin or caused by congenital absence of the parathyroids. So the main symptom of acute and sudden hypoparathyroidism is tetany. They will report numbness and tingling in the fingers or toes or around the lips, and a voluntary movement may be followed by an involuntary jerking spasm. They might have muscle cramping, a tonic flexion of the arm or finger. If the nurse taps the client's facial nerves, which lies under the tissue in front of the ear, the patient's mouth twitches and the jaw can tighten. The response is identified as a positive Chopsek sign. The nurse may also want to check for a positive Trousseau sign by placing a BP cuff on the upper arm, inflating it between the systolic and diastolic blood pressure, and waiting 3 minutes. If the nurse observes that the patient has a spasm of the hand while doing so, this is evidenced by the hand flexing inward. That is a positive Trousseau sign. They might also have a laryngeal spasm that can occur, which will cause dyspnea with long crowing respirations as air passes around the constriction. They might get cyanosis, and if they do, the patient is in danger of asphyxia and cardiac arrhythmias. Some of the symptoms they might complain about are nausea, vomiting, abdominal pain, and seizures. In chronic hypoparathyroidism, the patient will experience neuromuscular irritability, constipation or diarrhea, numbness and tingling of the arms and legs, loss of tooth enamel, and muscle pain. The positive Chopsek and Trousseau sign might be seen depending on the degree of hypocalcemia. To diagnose this, the serum calcium level is decreased and the serum phosphorus level is increased, and the urine levels of both are decreased. In chronic hypoparathyroidism, the radiographs will show increased bone density. So tetany and severe hypoparathyroidism are treated immediately by the administration of an IV calcium salt, such as calcium gluconate. Endotracheal intubation and mechanical ventilation may be necessary if acute respiratory distress occurs. We can also use bronchodilators. Long-term treatment after trauma to or inadvertent removal of the parathyroids includes administration of oral calcium, vitamin D or vitamin D2, which will increase the serum calcium level. The dose is related to the degree of hypocalcemia, which is determined by frequent monitoring of serum and urine calcium levels. Now, parathyroid replacement therapy with recombinant human parathormone is being investigated to normalize serum calcium and reduce the need for calcium supplements and vitamin D. So, as a nurse, we want to be alert for signs of tetany and assess for Chopsek and Trousseau sign. Monitor the patient with chronic hypoparathyroidism for increasing severity of symptoms. We want to prepare to administer IV calcium salt and observe the patient during such administration for adverse effects. So we want to watch out for flushing, cardiac arrhythmia, tingling in the arms and legs, and a metallic taste in their mouth. There might be local tissue necrosis that can occur if the IV medication escapes into the surrounding tissues, so we need to watch out for that. Also monitor their serum calcium levels to determine the effectiveness of therapy. Now, if the patient has chronic hypoparathyroidism, we want to make sure we're getting their complete medical drug and allergy histories. We want to examine the patient for symptoms of the disorder, primarily for the effect of hypocalcemia on the central nervous system. We're going to want to look at their legs and their arms, see if they have any muscle spasms, auscultate their lungs to see if they have any dyspnea or respiratory difficulty. And during the assessment of vital signs, we want to pay attention to the heart rate and rhythm because this is particularly important. The nurse will prophylactically keep an emergency tracheostomy tray, mechanical ventilation equipment, and artificial airway and endotracheal equipment at the patient's bedside following a thyroidectomy, or if hypocalcemia is severe. We want to insert an IV line for emergency administration of calcium and observe frequently for respiratory distress and notify the doctor if any of these problems occur. Adrenal insufficiency, which is also known as Addison's disease, is an inadequate production of steroid hormones and classified as either primary or secondary. So, primary adrenal insufficiency, which is Addison's disease, results from destruction of the adrenal cortex by diseases such as tuberculosis. It can also be an autoimmune disorder in which antibodies formed by the client's immune system will destroy the adrenal tissue. But in many instances, the cause is unknown. So the consequences of decreased adrenal cortical function include decreased available glucose and hypoglycemia. The glomerular filtration rate of the kidneys will slow dramatically, causing a decreased urea nitrogen excretion. Secondary adrenal insufficiency is the result of surgical removal of both adrenal glands, which is called a bilateral adrenalectomy. And it can also occur from hemorrhagic infarction of the glands, hypopituitarism, and suppression of the adrenal function by the administration of corticosteroids. Patients with secondary adrenal insufficiency after bilateral adrenalectomy or surgical removal of the pituitary glands don't experience true adrenal insufficiency because the corticosteroids are administered to replace the hormones no longer secreted by the adrenals. Now, when we assess for Addison's, we're going to notice that they have decreased or absent adrenocortical hormones that will lead to symptoms of adrenal insufficiency, which are the same in primary and secondary adrenal insufficiency. Patients with primary adrenal insufficiency usually experience symptoms gradually, and patients with secondary adrenal insufficiency will develop symptoms suddenly or over several days to weeks. Although many believe that President John Kennedy's tanned appearance was due to his outdoor activities, like sailing and playing touch football, it was actually more likely that it was due to his Addison's disease. So, a dose of synthetic ACTH, costantropin, is administered intramuscularly as a screening test for adrenal function. In primary adrenal insufficiency, an absent or low cortisol response indicates adrenal insufficiency. In secondary insufficiency, the decrease in serum cortisol levels is less significant. Now, the serum cortisol level is decreased, and serum sodium and fasting blood glucose levels are low, and serum potassium, calcium, and blood urea nitrogen levels are increased. The white blood cell count is often elevated, and a glucose tolerance test will show evidence of hypoglycemia. In Addison's disease, the glucose level in the bloodstream does not rise as high as normal and will return to its fasting level more quickly than it would under normal conditions. The fasting blood glucose level may be low, and radiographs of the adrenals will show calcification, and an abdominal CT might reveal atrophy of the adrenal glands. In treating this, patient with primary adrenal insufficiency will require daily corticosteroid replacement therapy for the rest of their lives. Fludrocortisone, a synthetic corticosteroid preparation that possesses mineral corticoid and some glucocorticoid properties, is frequently selected for replacement therapy. An additional glucocorticoid might be necessary depending on the patient's response to therapy. Treatment for secondary adrenal insufficiency, which is caused by bilateral adrenalectomy or pituitary failure, is the same treatment for primary adrenal insufficiency. Treatment of secondary adrenal insufficiency resulting from discontinuation of the corticosteroid or the hemorrhagic infarction of the gland will vary and depend on the ability of the adrenals to return to normal. If the patient has not given or does not take the medication, the acute adrenal crisis can develop. And this also applies to patients on long-term corticosteroid therapy for the treatment of disorders such as allergies, rheumatoid arthritis, and collagen diseases who abruptly discontinue taking their prescribed steroid. If the drug is to be discontinued, it has to be tapered over time. Patients with either primary or secondary adrenal insufficiency are at risk for Addisonian crisis, which is a life-threatening endocrine emergency. So, acute adrenal crisis will occur because the adrenal glands fail. Because the hormones of the adrenal cortex are prominent in facilitating the body's adaptive reactions to stress, patients with Addison's disease may develop acute adrenal crisis when faced with extreme stress. So even uncomplicated surgery will require more physiological adaptive ability than a client with Addison's disease usually possesses. So salt deprivation, infection, trauma, exposure to cold, overexertion, or any abnormal stress can cause adrenal crisis. Acute adrenal crisis can also occur when corticosteroid therapy is suddenly discontinued, and if the condition is untreated, coma and death can result. And assessing adrenal crisis, the adrenal crisis may be sudden or gradual. It can begin with anorexia, nausea, vomiting, diarrhea, abdominal pain, profound weakness, headache, intensification of hypotension, restlessness, or fever. Unless the corticosteroid dose is increased or restored to meet the demand, the patient will usually progress to acute adrenal crisis. The BP will usually decrease and shock will develop. In diagnosing this, it's all based on symptoms and history. The case finding can show an omission of daily corticosteroid therapy. So we have to remember adrenal crisis is an emergency, and death can occur from hypotension and vasomotor collapse. So we have to give corticosteroids intravenously in solutions of normal saline and glucose, and also antibiotics can be administered because of an extremely low resistance to infection. Pheochromocytoma is a tumor of the adrenal medulla that can cause hyperfunction. So a pheochromocytoma is usually a benign tumor. And hyperfunction causes the adrenal medulla to secrete excessively the catecholamines epinephrine and norepinephrine. Exercise, emotional distress, trauma such as surgery, manipulation of the tumor, and postural changes can trigger episodic symptoms. Excessive secretion of epinephrine will lead to hypertension and increase the potential for a cerebrovascular accident, palpitations, and tachycardia. Those that should be assessed for pheochromocytoma include those who have hypertension that's difficult to control, take more than 4 medications to control their blood pressure, and develop hypertension before 35 years of age. In assessing, symptoms will include elevated blood pressure, which can be intermittent or persistent, tremors, nervousness, sweating, headache, nausea, vomiting, hyperglycemia, polyuria, and vertigo. So the level of vanilla mandelic acid in a 24-hour urine specimen can actually be increased, and urinary catecholamine determination on the same or different specimen can be also elevated. We can do CT, MRI, ultrasonography, aortography, and retrograde pyelography, and all of these things can reveal the tumor. A drop in blood pressure after a test injection of the alpha-adrenergic blocker phentolamine will support the presence of a pheochromocytoma when compared with baseline measurements. In treatment will involve surgically or minimally invasive laparoscopic removal of the tumor by means of unilateral adrenalectomy. Phentolamine is given before and during the surgery to control hypertension, and alpha adrenergic blockers such as phenoxybenzamine are used to control hypertension before surgery or when surgery is contraindicated or to treat a malignant pheochromocytoma. Medical treatment can include metrizine and an enzyme inhibitor that reduces synthesis of catecholamines to decrease hypertensive attacks. Cushing syndrome is an endocrine disorder that results from excessive secretion of hormones by the adrenal cortex. So, an overproduction of adrenocortical hormones results from the overproduction of ACTH by the pituitary gland, with resultant hyperplasia of the adrenal cortex and excessive production and secretion of glucocorticoids, mineralocorticoids, and gonadocorticoids. Also from benign or malignant tumors of the pituitary gland or adrenal cortex, or prolonged administration of high doses of corticosteroids. These patients who take corticosteroids are advised to continue taking them and avoid discontinuing their administration abruptly to avoid Addisonian crisis. When these types of medications are no longer necessary, they can be discontinued gradually. Hyperadrenalism affects most body systems and will cause changes in appearance and physiology. And the term Cushingoid syndrome will refer to the physical changes that accompany this disorder. Some examples of physiological alterations include suppression of the inflammatory response, hyperglycemia, hypokalemia, hypernatremia with subsequent weight gain and elevated blood pressure, peptic ulcer, demineralization of bones, and muscle weakness. Increased levels of adrenergic gonadocorticoid hormone can cause women to acquire male secondary sex characteristics, and people of both genders will experience decreased sexual drive. Most patients will suffer from depression, and the endocrine imbalance may cause psychosis. So when we do their physical examination, it'll reveal muscle wasting and weakness resulting from extensive protein depletion. Carbohydrate tolerance is lowered with signs and symptoms of diabetes mellitus. Their fat will be redistributed, leading to facial fullness and the characteristic moon face and buffalo hump. The skin will be thin and the face ruddy, and the patient has increased susceptibility to wounds and healing will be prolonged. However, the immunosuppressive effects of this disorder usually will mask the symptoms of infection. Now, because our blood vessels are so fragile, we find that the patient will bruise pretty easily and striae will often form over extensive skin areas. The bones will also become so demineralized that the patient might have a backache, kyphosis, and collapse of the vertebrae. They tend to retain sodium and water, and peripheral edema and hypertension usually develop because of this. They also might report mood changes and difficulty coping with stressors that might have been something manageable in the past. They will report serious mental changes, and in women, Cushing syndrome will produce masculinization with hirsutism and amenorrhea. These sexual changes and alterations in appearance are reversible when adrenocortical hormone levels return to normal. In diagnosing, it's tentatively based on physical changes. So urine levels of 17 hydroxycorticosteroids and 17 ketosteroids usually are increased. The plasma and urine cortisol levels are elevated, and an overnight dexamethasone suppression test is used as an initial screening. The client usually takes 1 milligrams of oral dexamethasone the next morning. Plasma cortisol levels are obtained. Now, if these results are above normal at 5 milligrams, 0.5 milligram dexamethasone is given every 6 hours, and 24-hour urine collections are tested for 2 consecutive days. Patients without the disorder have decreased 17 OHCS levels and decreased 17 Ks levels, and these levels remain elevated in those with Cushing syndrome. Now, to determine whether the symptoms of Cushing syndrome are the result of pituitary stimulation, plasma ACTH is measured in conjunction with the administration of dexamethasone. If ACTH levels subsequently are found to be low or normal and the cortisol level is elevated, it actually suggests that the adrenal gland alone is hyperfunctioning. If both the ACTH and cortisol levels are elevated, a pituitary or hypothalamic etiology is more likely. We can also do lab blood test results that'll reveal increased serum sodium, decreased serum potassium, and increased blood glucose levels. Abdominal radiographs, CT, MRIs can show adrenal enlargement, and an IV pyelogram can show changes in the renal shadow caused by an abnormally large adrenal gland. In order to treat this, treatment depends on whether a rumor or adrenal hyperplasia causes the disorder. It's directed toward removing the cause and lowering the plasma cortisol levels. Radiation therapy or removal of the pituitary gland may be used for adrenal hyperplasia, and bilateral adrenalectomy may be preferred if both adrenals are involved. Some drug therapy that's included for edema, as well as an antihypertensive agent. We want to give them a diet low in sodium and carbohydrates, which controls the edema and blood glucose level, and antibiotics that'll be used to treat infection. If Cushingoid syndrome will result from exogenous administration of a corticosteroid preparation, the drug will then slowly be withdrawn by tapering the dose over a few days or weeks. In some instances, as in the treatment of a disorder such as leukemia, or to prevent rejection of transplanted organs, the syndrome is allowed to persist. Hyperaldosteronism is due to the excessive secretion of aldosterone, leading to extreme electrolyte imbalances. Aldosterone is a mineral corticoid which is regulated by serum levels of potassium and sodium, the renin-angiotensin system, and ACTH. So the cause of primary hyperaldosteronism may be a benign aldosterone secreting adenoma, an adrenal malignant tumor, or unknown. Pregnancy, heart failure, narrowing of the renal artery, and cirrhosis can cause secondary hyperaldosteronism. Excessive secretion of aldosterone results in increased reabsorption of sodium in water and excretion of potassium by the kidneys. When we are assessing, there's usually a cluster of signs and symptoms that will develop, and this includes headache, muscle weakness, increased urine output, fatigue, hypertension, and a potential for cardiac arrhythmias. We find that serum potassium levels are decreased while serum sodium levels are increased in the absence of other causes such as diuretic therapy or diarrhea. The serum bicarbonate and serum aldosterone and plasma renin levels are also increased. So in order to diagnose, we can use a CT or an MRI, and that can rule out or locate an adrenal tumor. But with the really small tumors, the CT scan might fail to reveal those, so we would use adrenal venography. Now, if the cause is an adrenal tumor, a unilateral adrenalectomy may be performed, and some medical management we can do is administration of spironolactone, a potassium-sparing diuretic, and an antihypertensive agent used to control the blood pressure. We can also restrict their sodium in their diet as necessary.